Welcome to the OMMedicine's module on chronic lymphocytic leukemia. Chronic lymphocytic leukemia, or CLL, is a B-cell neoplasm, and as the name implies, it is chronic and not acute, so we would not expect to see blast cells on a peripheral smear. And this is typically going to be a cancer of older adults. You will usually see it in patients greater than age 65. Now, the presentation of CLL is going to have a lot of overlap with some of the other hematologic cancers. So CLL may even be found incidentally or on routine exam. They may have painless lymph node swelling, which remember is a major way to help differentiate it from some of the other causes of lymphadenopathy. And then a minority of patients may also have some of your classic B symptoms. Now, in physical exam, we would expect to see painless lymphadenopathy and painless splenomegaly, and then we can also see some characteristic skin changes which can be highly variable. Collectively, they are referred to as leukemia cutis. However, there's really no one specific type of skin change that you would expect to see. It can be macules, papules, plaques, and so on. So if the patient is over age 60, and they have all of these findings such as painless lymphadenopathy and excessive fatigue and maybe even some splenomegaly, then we would want to start thinking about a possible hematologic cancer such as CLL. And so the major way that we will go ahead and diagnose a patient with CLL and really any of the hematologic malignancies is going to be with routine labs such as a CBC, flow cytometry, and then a peripheral blood smear as well. And so the combination of the three of these will typically be enough to give us a diagnosis. So on a typical CBC, we would expect to see lymphocytosis, and this is going to be greater than 5,000 B cells for greater than 3 months. And this is a very important number to remember because we'll talk about in just a minute something called SLL, in which all of the presentation and findings are going to be very similar to CLL. However, the white blood cell count will need to be less than 5,000. And so whether it's greater than 5,000 or less than 5,000 is a very important number to remember to distinguish the diagnosis between CLL and SLL. We would also expect to see low levels of immunoglobulin, and this is going to be for all forms of immunoglobulin. So IgG, IgA, and IgM should all be low. And remember, this is going to be another way to distinguish it from some other diagnoses, such as immunodeficiencies, where you may only have a deficiency of IgA or IgM, for example. On peripheral smear, we would expect to see something called smudge cells, sometimes referred to as basket cells. And you should take a minute and Google a picture of what these look like for your board exams. I've always thought they kind of look like jellyfish, but nonetheless, you should just be familiar with what they look like. Now, we can also do something called immunophenotyping, which is done via flow cytometry, and this is really just a fancy way to determine what the actual markers are on the surface of each cells. And so in this case, we would want to know what the markers are on the abnormal cancerous cells that are growing so that we can find out what specific type of malignancy it is. Now for CLL, we would expect to see the typical B-cell markers because this is a B-cell malignancy. So you can see CD19, CD20, or CD23. However, you would also expect to see CD5, which is a typical T-cell marker. It would be somewhat unusual to see CD5 on a B-cell, and so what is sometimes called the co-expression of CD19 and CD5 or CD20 and CD5 would be highly indicative of CLL. So on your board exams, they'll typically describe a cell that comes back and it's CD20 and CD5 positive, and this should clue you in that you're probably dealing with CLL. Now, some of the other techniques that can be performed to aid in the diagnosis of CLL are lymph node biopsies and bone marrow biopsies. Now, lymph node biopsies are a little bit more common in the diagnosis of CLL versus bone marrow biopsies, and bone marrow biopsies are not required in the diagnosis of CLL. However, they can be done if all of the other items, such as the flow cytometry and lymph node biopsies, are inconclusive. So if we were to get a lymph node biopsy and send it off to pathology to look at under a microscope, one of the major key findings that you should be familiar with, especially for your boards, for the diagnosis of CLL is going to be something called pseudofollicles, and these are a pathognomonic finding of CLL. Now, the classic description of pseudofollicles, which if you're taking level 1 or step 1, you definitely need to be familiar with. However, once you've gotten past that point, it's less commonly tested. Regardless, it is going to be described as having large lymphoid cells with prominent nucleoli and scattered chromatin. Now again, unless you have an interest in pathology or taking the level 1 or step 1 exams, it'd be a lot less likely that you're tested on this description. And so the way I've always remembered it is, depending on the stain that they're using, it will look like a bunch of pale circles in a background of purple cells. And so you can use that if you'd like, but knowing that pseudofollicles or indicative of CLL is the most important finding. And as we previously mentioned, a bone marrow biopsy is not required to make the diagnosis of CLL. However, if it were to be performed or this finding was given to you on a board exam, you would expect to see greater than 30% of all nucleated cells being lymphocytes. Now let's talk about the treatment or management of patients with a confirmed diagnosis of CLL. And it's important to note that not all patients who are diagnosed with CLL are going to require treatment. So there is no official cure for CLL, and the lifespan of patients who have CLL but do not receive treatment is about the same as the regular lifespan of the general population without CLL. And so therefore not all patients with CLL are going to require treatment. Now there are some indications for treatment of patients with CLL, and I've listed some of the major ones here. Now this is typically going to be more of a clinical judgment call by the physician rather than something you are likely to be tested on. And I just want to mention a few of the indications briefly because sometimes they are tested. And so two of the major indications for treatment of CLL are going to be massive or progressively symptomatic splenomegaly or lymphadenopathy. And then if you have a patient with progressive and worsening lymphocytosis, these patients are typically indicated for treatment as well because you will get an increase in the viscosity of blood, which can then cause a lot of other complications down the line. So if a patient does meet an indication for the treatment of CLL, then we can go ahead and discuss with hematology and oncology what regimen would be best for them. However, there's not typically one specific drug to memorize for the treatment of CLL that would at least be relevant for your board exams. Now, there are several complications that are associated with CLL and that I have listed on this slide. One of the major paraneoplastic syndromes associated with CLL is MPGN, or membranoproliferative glomerulonephritis. You can have autoimmune hemolytic anemia, infections, pure red cell aplasia, ITP, which we discuss in another video as well. And then one of the major ones to be familiar with your boards and for the treatment of CLL is going to be the progression of CLL to diffuse large B-cell lymphoma through something called the Richter transformation. And the Richter transformation is one of the feared complications of CLL because we go from a relatively quiet malignancy in normal CLL to a more advanced and somewhat aggressive malignancy in the diffuse large B-cell lymphoma. And typically the way that this will present will be a patient who has a known history of CLL and they develop a rapidly growing lymph node or spleen, and then they have worsening of symptoms, and you will need to biopsy whatever that rapidly growing lesion is, and then on pathology you will see that it's not your typical CLL but rather a diffuse large B-cell lymphoma. And from a USMLE and COMLEX standpoint, the progression from CLL to diffuse large B-cell lymphoma is probably the most high yield complication of CLL to be familiar with. Now we also need to mention something called small lymphocytic lymphoma or SLL, which I alluded to earlier, and for all intents and purposes this is really the exact same thing as CLL with one major diagnostic difference, and that's going to be that the absolute lymphocyte count is going to be less than 5,000, whereas remember for CLL it's going to be greater than 5,000. And so for your board exams they will describe a patient who meets all of the criteria for CLL as we previously discussed. However, the absolute lymphocyte count will be less than 5,000 and they will have CLL as the answer. However, you need to be sure that you are looking for SLL because that's really going to be the only major difference between CLL and SLL. And that brings us to the end of this module on chronic lymphocytic leukemia.